Basic Principles of Internal Fixation. This is from the OTA Core Curriculum Resident Lecture Series version 5. Slides are by Dr. Steve Papp, and I am Saqib Rahman narrating. In the first video, we talked about the sort of mechanical biology of fracture healing and the normal fracture healing process. We talked a little bit about screws and mechanics of screws and different types of screws and screw techniques, anatomy of screws. So now let's talk a little bit more about plates and plate mechanics and plate function. So there's different types of plate function. So again, you're not going to ask your scrub tech, can you please give me the compression plate? You are going to take a plate and use it in a compression function or use it to neutralize. And that is, or, if you're going to use a screw, you're going to use a screw in lag technique or position screw. You don't say, hand me the position screw. So similarly, these are plate functions. A plate can function as a neutralizing plate, a compression plate, buttress or antiglide plate, or a bridge plate. So a plate can have one of these functions. So for neutralizing, this is something that is commonly done in a spiral pattern. So for example, distal fibula is a very common example many of you may see where you use interfragmentary compression lag screws to primarily fix the fracture. And here you can see there are two independent lag screws sitting outside the plate. And then there is a neutralizing plate. That neutralizing plate is done afterwards, and that is to protect the fracture and the lag screw fixation from shear forces or rotational torsional forces that could otherwise disrupt your fixation. So it neutralizes those forces. What about compression plates? Now, with compression plates, this is a way to help achieve absolute stability in primary bone healing. You have to get an anatomic reduction. And the way this is done is you have to drill eccentrically. So let's say instead of drilling your hole in the center or drilling in the center of your screw hole, this is sort of your plate hole there. The plate potentially has this like sort of ramp here. And what you do is you drill all the way at this side of the screw hole. All right, so you drill eccentrically rather than in the center. And sometimes your drill guide may provide this for you. So now the screw is engaged in bone, but as this screw head comes down and it's got this sort of shape like this that forces it to want to center itself here. It wants to slide down this ramp to here. So as it does that, the screw is fixed in bone. It's not going anywhere. So the only thing that can move is the plate. So the plate will move this way to allow that screw to center itself in the hole. So if there's a fracture over here and the plate's being pushed this way, this can allow the plate to compress the fracture. And you're only seeing one side of it here. You're not seeing the entire plate, but that is how you get the plate to sort of move. And if the plate is otherwise fixed on the other side of the fracture, that will allow this fragment to move this way, and relatively speaking, for compression. So if you apply if you use a straight plate, this is another concept to understand. Plates are eccentric, right? It's not a compression device placed in an intramedullary fashion. So if you have a perfectly straight plate on top of a straight bone like this with a transverse fracture, as you compress, what can happen is you can get this gapping here on the far cortex, right? So this can happen if you take a perfectly straight bone, or let's say you've done an osteotomy and you put this plate on, you start compressing, it's going to do that. So what you can do to avoid this is take the plate and make a slight bend initially. Then when you put your screws in, you're already sort of loaded here, and that's not going to gap. So by pre-tensioning your plate, this can avoid distraction at that far cortex. So here's an example. This is a patient who decides to undergo surgery for a humeral shaft fracture. It's somewhat of a short oblique. Looks like compression plating is a good option. So the fracture is fixed with lag screw compression plating, and you really want to aim for compression across the entire fracture. And you can see there's a small gap on the far cortex. Perhaps could have been this could have been pre-tensioned a little bit better to avoid that. Here's another way you can achieve compression. This is with an articulated tensioning device. So here you can see the plate is placed. There's fracture is here. Screws are placed on the other side of the fracture, and now you want to compress. You know, you have fixation here. Maybe there's fixation up here, and you want to compress this way, right? So there's no screws on this side here, right? But instead, you put this tensioning device that has to lock into the bone. And then what it does is it causes, you turn this knob and it causes this to get pulled this way. And then once it's compressed, then you go ahead and fix here, and then you take this device off. So that is another way you can achieve compression using certain devices like an articulating tensioning device. What about buttress plating? So here's an example of a tibial plateau fracture. There's going to be shearing force with weight bearing. So what you can do is do a buttress plate. Now, when you do this, there's multiple things being shown here, by the way. You can see there's some lag screw, partially threaded screws compressing across this articular fracture with anatomic reduction. But what you will see is that if you want to buttress this, you have a slightly under-contoured plate. So as an extreme example, let's say your plate was not contoured at all, right? And it's straight. Well, as you put this screw at the apex of the fracture, this is going to generate a lot of sort of compression up against here, and that will cause this fragment to compress. So if you put a cortex screw here, not a locking screw, but a cortex screw, it's going to pull the plate to the bone, and you have to know how much pull-out strength you can expect from the cortical bone that you're dealing with, and you have to understand how much to under contour and not have the screws pull out. But you can understand how that's going to really generate compression here, as opposed to if you had an over contoured plate and the plate was like this. Let's just say, when you put this screw in, this part of the plate's not doing anything. It's not even contacting the bone, so it's not going to generate compression. So you have to be a little bit under contoured when applying a buttress plate. So it has to be a little straighter than the bone, and then as you achieve buttressing, you'll get compression, and then you can finish that off here as shown with lag screws across the fracture as well. So antiglide is a similar concept, and this is placed over the axilla of the fracture. So here you can see there's a posterior medial sort of fracture. What they want to do is get there. You want to sort of just imagine you get your thumb and pushing that in, right? So that is achieved with this anti-glide plate here, which sort of just captures that apex of the fracture to prevent it from shearing distally. So bridge plating is a technique used for comminuted fractures. So just imagine this entire area here was all comminuted. And in a femur, that would be a great option to do a nail for. But let's say you can't do a nail, or you're plating for whatever other reason. Maybe it's not amenable to a nail, or for whatever reason. So you can do bridge plating, and this is a form of relative stability. You're bridging the proximal portion to the distal portion and leaving all those intermediary fragments unfixed and untouched, and allowing the biological healing process to proceed. So all the stability is transferred to the plate. So there's really no you're not getting bone-to-bone contact. So your plate's doing a whole lot for you, and you have to make sure that it's strong enough to withstand these forces. And until it starts healing, there's really no stability conferred by the bone itself. So these can be done for comminuted fractures. It can help to preserve that fracture biology. You can often insert percutaneous screws to avoid opening near the fracture. And this can help to restore length, alignment, and rotation. So the optimal stiffness for optimizing bone healing, it's unknown. So, Perrin's strain theory, and I believe it's... So Stephen Perrin, I think there's a typo there. So I do want you to consider looking this up. It's a little bit is a little more contextual than we can cover in this short lecture. So I encourage you to look that up to understand this whole concept of strain theory. And healing is improved when a small amount of motion and strain is allowed. The ideal is 10 to 30% strain, depending on your gap. This is a sort of a quick summary of strain theory and why, for example, this is a good concept, a comminuted fracture can tolerate slightly more strain. So imagine you have a gap, and remember, strain is change in length over length, right? So if you have a gap, or the length here is 5, right? And the change in length is 5 as well. So so the change in length is 5 and the length is 5, then the strain is 100%, right? So 5 over 5 is 1. Now here, if you apply the same delta L, right? But each gap shares that delta L. So it's a total delta L of the same amount of strain. So these two patients, in this case, are experiencing the same amount of deformation. But in this case here, all of the deformation is concentrated at one area, one fracture gap. Here, there are 5 fracture gaps, right? The total adds up to, each one is 5, but each gap only experiences 1 millimeter of strain. So when you apply the same amount of force, it's distributed 5 times, right? So each gap experiences, a delta L of 1, right, over a length of 5. So the gap is the same, but this is distributed into 5 gaps. So that equals 0.2 or 20%. All right. So the strain in this comminuted fracture is much less. Why? Because if you make a lot of these things equal the same amount of deforming force, the same size gap, but now that force is distributed, the same amount of force distributed amongst many gaps, each gap experiences less strain. Okay, so that's why a comminuted fracture here can tolerate more strain, and a simple fracture sees a higher strain environment. So if your bridge plating construct is too stiff, then you may have very little callus because there's really no strain. Union can be delayed. If it's flexible and you see some strain, you'll get bone healing, and that's what you want. And if the construct is too flexible and unstable, then you just have too much motion, and you can get a non-union or a hypertrophic non-union, for example, due to too much instability. So this is the balance you have to figure out, and that can be challenging, how to apply strain theory to practice. So this is that sort of spectrum of stability where you have absolutely no motion. If you're going to do that, you should have absolute stability, compression, and excellent anatomic bone contact. And if you have no stability, there's excessive motion, then you're at risk for non-union. If you have relative stability, that could be a bridge plate, that could be intramedullary nail, that can be appropriately, applied casting technique. It could be external fixation. And those are some examples on the left of absolute stability: compression plating, lag screw fixation with a neutralization plate, buttress plate fixation. We saw an example with lag screws. Tension band we haven't talked about too much, but that's also anatomic reduction and compression. Now, many plates are pre-contoured now, which makes things easier to attempt to match normal anatomy, allows the plate to be lower profile. It allows more screws in a short segment, shown here. It allows for more points of fixation in that short segment, and you can have these combi plates where you have both locking and non-locking traditional screws. So you can kind of reduce the plate to the bone, but then also use locking screws. That said, these are designed for the average patient, so it's not going to fit everybody. And if it's not a good fit, it could mal-reduce the fracture and can be prominent also. So there's advantages and disadvantages here. You can see there's a plate mismatch. So people always ask you how many screws, where to put the screws. I mean, these are some general rules of thumb in the forearm. 3 bicortical screws on either side of the fracture, and then in the humerus, femur, it's going to be more like 4 or 5 on either side of the fracture. But it's not really just the number of screws. You have to think about everything else that we talked about. It depends on the type of construct you're doing. And in general, less screws over a longer span are probably better than more screws over a short span. So where, your screw number and spacing depends on what you're measuring. Is it axial load? Is it bending? Is it torsion? Is it some combination? So here are some examples of different constructs that you can create, and references below for you. Ultimately, the working length itself, and we talked about this in a different video, is more important than the screw number. So, for example, as you see, in example D here, you have a long working length here with 2 screws compared to here. Right, so this can tolerate much more deformation, and the stress is distributed much better across here with a longer working length than you have with this short working length. So that's what's more important. Because here, you can put in another screw here. You're still going to have area of high stress at that screw right there that you can avoid by doing a longer plate. So how stiff should the construct be? Well, where you place your screws is going to affect that. So, the optimal working length and bridge span, it's something we're still trying to fully understand. I mean, we do know that a longer working length equals less stiffness, and shorter working length is something that's more stiff, but you may not want to have too much stiffness, for example. So if I wanted more flexibility in this construct, I might actually remove these 2 screws. But then does that become too flexible? Well, it depends on what you're dealing with. So here, that is your working length. So, for bridge plating in general, you want a long plate with a wide screw span, and you may want to leave some empty screw holes near the fracture site. So for example, shown here, if you want to distribute your stress, you might leave those screw holes open if you're going to be bridge plating this, as opposed to having a screw, very close here and concentrating everything into one spot. Now, this is a little bit of a tricky example because you're showing this one gap. Now, if you're truly doing bridge plating, you probably want more of a comminuted fracture here. If you had a simple fracture like this, you probably would not want a bridge plate like this. And it's really just unclear what's the best strain environment for fracture healing. So what about locked plating? So conventional plating relies on friction at the bone plate interface. So the plate gets sucked down to the bone, and that could be great to improve stability. Also, if your plate is properly contoured to ultimately how you want the bone to be, getting the plate to bone will help you reduce the fracture. The locked plate will not do that, at least not when you're using the locking screws. It doesn't rely so much on the purchase of the screw and bone, and the plate can sit off of the bone. But this screw is not going to toggle. It's not going to move in this direction, or three-dimensionally. I can't show that here. It's going to be a fixed angle. It's going to create this fixed angle here. So that's how it's different than a cortical screw here that can potentially. I'm not showing that it's moving relative to bone, but this thing, instead of being here, it can move like this or like this if the screw loosens. There's no fixation of the screw head to here. So this is where that toggle can start, and that's less likely to happen with a locking screw. In fact, it can't happen. So here is an example on the right-hand side of conventional plate fixation. You put in your screws as you, this is, demonstrating compression plating. As you put your screws in, the plate is going to come down to the bone. And as the patient loads, you have this friction force with a locked plate. As you put your screws in, you're relying on compression, strength of the bone. With regular screws, as I showed before, you can have this toggle, right? So with regular screws, with a bending load, you can pull out, as shown on the left-hand side here, where the screws are pulling out of bone. And if you have locking screws, it'd have to really windshield wiper, right? It would have to sort of, there's a much larger area you would have to sort of cut through. So there's a much larger resisting area to prevent that from happening. So what about this angular stability? If you have a non-locked screw, like on the left, as you load, you potentially can have toggle, right? And you have no, going back, you have no bone contact here, right? So because of that, this can toggle and create this deformity with the screws loosening, right? Now you have this deformity, as opposed to the load on the right-hand side with the locked screw, you have a fixed angle construct. So that's not allowing that to deform. Also, the term internal external fixator is used sometimes because, the plate is not sitting on bone. You just, and this is a unicortical locked screw technique down here. So you're not crushing the periosteum, and you're not, and potentially you could say preserving some of the blood supply there. What about intramedullary nails? Well, you can think of it somewhat of an internal splint. You also are looking to achieve relative stability with callus formation, with a goal to establish length, rotation, and alignment like you would with a bridge plate. And you're not trying to get anatomic reduction of like all these pieces here. And if you leave that alone and let the biology cascade of healing take place, you will hopefully get this nice callus formation seen here. There are different options. There's reamed versus unreamed. If you reamed, you can put in a little bit of a larger nail, but at the cost of some additional endosteal damage. You can do interlocking screws, or potentially be unlocked. Most of the time we do interlocking screws. You can have static versus dynamic interlocking. But in general, reamed statically locked nails are the standard of care for certainly like for femur fractures, for example, and tibia fractures. So stiffness is affected by the diameter of the nail, right, to the fourth power. So a very powerful way to increase your stiffness. By nail materials, we talked about in a different lecture on biomechanics. By bony anatomy, how you do the interlocks, and of course the fracture location. So here's an example of an intramedullary nail fixing a femur fracture. How could we have made it more stable? Notice there's a large space in the metaphysis here. You can argue that a larger nail could have made it more stable. Possibly if you had placed blocking screws here to prevent this rod from moving back and forth, that could have helped to lock it in place. So a larger nail, more locking screws, blocking screws, maybe adding a plate. So here's an example also showing where you could put blocking screws. And the distal femur is a great example of this, where you can have, as shown here, this sort of bell clapper effect, where you have potential instability because of this sort of, up here you can see how the rod is right in the middle of the cortex, whereas down here there's all this space for the rod potentially to toggle a little bit. And by putting blocking screws in, you can prevent that from happening. You even put them proximally as well. Consider the biomechanics in each case. You have to consider reduction, nail size, where to put locking screws, how many, blocking screws. Sometimes you have to consider adjuvants like cements or a plate. for example. So these are all things you can do to alter the biomechanics in your situation. So to summarize, we talked about fracture personality, patient characteristics, and helping determine your construct. Often simple fracture patterns and intra-articular fractures are treated with anatomic direct reduction and absolute stability, where you can get compression and primary bone healing, whereas complex comminuted fractures, sometimes you can treat more with indirect reduction and relative stability. We didn't talk so much about reduction in this lecture, but those are terms you should be familiar with. The exact amount of instability is still unclear. I mean, how much do we need? It's hard to know, but there is this balance between being too stiff and being not stiff enough. Goal of relative stability, intramedullary nailing or bridge plating, is accurate restoration of length, alignment, and rotation, right? We're not trying to piece every diaphyseal fragment back anatomically. But regardless of the fixation method, the tissues are biologic, and you should try not necessarily to just always achieve maximal stability, because that can maximize soft tissue trauma, but you want to try to balance that with minimizing soft tissue trauma and stripping of the soft tissues. So that'll wrap things up. Here are some references for you. And again, Rockwood and Green is a great resource, I think, for these basic principles.